Hello and welcome to this session on nut immunotherapy. Is it ready for prime time? Apologies that I cannot be there in person as I will be on a plane at the moment. I'm very excited to give this talk to you and I'm very interested in this area, and I think that there are some great progresses that have been made in recent years. What am I going to talk to you about today? The first thing will be, what do people want from food immunotherapy? Because we need to make sure that we are catering for people's needs. Then I will be providing some updates on oral peanut immunotherapy, epicutaneous peanut immunotherapy, sublingual peanut immunotherapy, and then some practical considerations with a video. So this is data from the UK with regards to fatal food anaphylaxis. And we can see here that the majority of fatal food anaphylactic reactions occur due to peanuts and tree nuts. And in children, a close second is milk. This is some data from Paul Turner et al., who showed that the highest rate of fatal food anaphylaxis is for children aged 10 to 14 years of age per admissions. And you can see here the report of a girl, 12, who died from an allergic reaction to eating a chocolate Brazil nut. So we need to make sure we're getting in before this time to protect these patients from fatal food anaphylaxis. And how does this work in terms of the modelling? So a lot of the work in peanut and other oral immunotherapies is based on increasing the baseline threshold from less than 100 milligrams of the nut protein or other food protein to 300 milligrams. And by this modelling showed that you were able to reduce the risk of experiencing an accidental reaction by 95%. However, this type of accidental exposure protection is perhaps what people were initially looking for, but once they get it, and I've seen this in my clinic, they then want to consider other things. So initially you may have desensitization at low dose, which reduces the chances and severity of accidental reactions whilst the patient remains in food avoidant process. Then you have desensitization at high dose, and this would mean that potentially the freedom to eat the food whilst maintaining regular intake of a given dose. And then you have sustained unresponsiveness, which is then able to have a free diet where the patient can have a full freedom to take the dose and does not need to continue to take the therapy on a regular basis. And this has important implications depending on which type of immunotherapy you're doing, whether that's oral immunotherapy and not having to avoid doing sport for 2 hours, whether that's patch immunotherapy and not having to put a patch on your bag, or sublingual immunotherapy and having to take the drops. So in terms of oral peanut immunotherapy, we've all seen the marvelous work that was done to enable licensing of the Palisade peanut oral immunotherapy, which was published now in 2018 and showed that in highly allergic children and adolescents with peanut allergy, that on the children that were on treatment, 67% of them were able to tolerate 600 milligrams of peanut protein without dose-limiting symptoms versus 4% only in the placebo arm. However, there were severe adverse events, 4.3% in the intervention arm and only 0.8% in the control arm. This was then replicated to a certain degree in younger children between the ages of 1 to less than 4 years of age in the Poseidon trial, and in this trial, which was also placebo-controlled, they used Palforzia, and their primary endpoint was also subjects who could tolerate at least 600 milligrams in a single dose of peanut protein with no more than mild allergic symptoms. And these are the results from the Poseidon study, which was published in the New England Journal of Medicine Evidence. And this showed that almost 80% of children were able to tolerate 300 milligrams, 73% were able to tolerate 600 milligrams single dose, and 68% were able to tolerate 1,000 milligrams at a single dose. As this was better than was shown in the Palforzia trial. In terms of safety also, you could see that there were some differences between Palisade and Poseidon. And this is important because there was a very landmark study by Chu et al. In the Lancet, which showed that by doing immunotherapy to peanut, you're much more likely to have anaphylaxis and need to use an adrenaline autoinjector than if you don't do immunotherapy. And in the systematic review that they did of peanut oral immunotherapy, which, mind you, was in an average of 9 years old children, 16.5% had had a severe allergic reaction. Now, looking at the Palisade versus Poseidon, the treatment-related systemic allergic reactions were 14.2% in the older children, and then only 2% in the 1 to 3-year-old children. What's very important to note is that the severe allergic reactions were 4.3% in Palisade, but were 0 in Poseidon, showing potentially in this age group that it is safer to do this. And then in a real-world Canadian preschool peanut oral immunotherapy data trial, which was an average of 23 months of age, 0.4% of these had a severe allergic reaction, which is very reassuring given that in the real world, people are perhaps less likely to have as much input than in the rigorous settings of a clinical trial. And then the impact study was also something that really innovated this area, because this group of investigators looked at, again, highly allergic children with peanut allergy that were young, between the ages of 1 to 3 years of age, and then they put them onto a maintenance dose of 2,000 milligrams of peanut protein for 30 months. So they were on this for 2.5 years. And then they looked at a concept that they called remission, which was where the children who were in the intervention arm were asked to stop eating peanut for 6 months. And then they had shown that they were desensitized when they were assessed at 30 months with a double-blind placebo-controlled food challenge of 5,000 milligrams. And then they had this challenge repeated 6 months later to assess for sustained unresponsiveness, which is the longest period of time to date that has been done for sustained unresponsiveness in oral immunotherapy. And what they showed was that there was a high rate of desensitization, but a lower rate of remission in the peanut oral immunotherapy group versus the placebo group. And you can see here that in the intention to treat group, 71% of children were desensitized, but note these were very, very allergic children. And in the per protocol group, this was 84%, which is high, versus very negligible amounts of children being able to tolerate the challenge in the control arm. Now, the remission was lower than the desensitization, as would be expected. In the intention to treat arm, this was 21%, and in the per protocol arm, this was 29%. But what the investigators did was that they looked at what types of indicators would help us to know which children are more likely to develop sustained unresponsiveness or remission. And they found that it was the youngest children between the ages of 12 and just under 24 months that had the highest chances of sustained unresponsiveness at 71%. And this gradually reduced to 35% in the 24 to 36 months, and then down to 19% in the 36 to 48 months children. They also found that for every 10-fold increase in baseline peanut-specific IgE, the odds of remission reduced by 88%, which is a lot. So the children to be targeted that we think may be able to obtain remission are those that are youngest and with the lowest peanut-specific IgE. This is another study which looked at combining peanut oral immunotherapy with a probiotic, and this showed that in the 3 different groups they had probiotics with peanut oral immunotherapy, or placebo with peanut oral immunotherapy, and then 2 placebos. They took children which had peanut allergy confirmed on double-blind placebo-controlled food challenge, and they were randomized 1-to-1 with the intervention arm, and then half of that with the placebo arm. And they underwent this treatment for 18 months, and then they were assessed also for sustained unresponsiveness. What they found, which was very interesting, was that there was no difference in efficacy rates depending on whether you did peanut immunotherapy with or without probiotics for desensitization, and also the 8-week remission or sustained unresponsiveness start of that trial. But what they did, which was an a priori assessment of looking at different age groups, was that in the group of children between 1 and 5 years of age, desensitization was achieved in 83%, and remission was achieved in 58%, whereas in the older group, this was much lower, desensitization in 67% and 8-week remission in 37%, which indicates that oral immunotherapy may be more effective in younger children compared to older children. Now, what about other sources of immunotherapy? So there is the epicutaneous peanut immunotherapy, which you can see here, which applies peanut protein at 250 microgram dose. So beforehand we were talking about milligrams. In this situation, it is micrograms. So the Paediatric study, which was done and was published back in 2019, they looked at children who again were highly allergic to peanut, with a median age of 7 years. And they applied the peanut patch, 238 in the intervention group and 118 in the placebo group. And they looked to see what the response rate was after 12 months of treatment. Now, there was a difference of 21.7% in terms of the peanut patch versus placebo, but this did not meet the primary endpoint, which had been pre-specified by the FDA. So this group also did the younger age group with the epitope study, and they showed in this cohort of children that there was a substantial benefit, with a 67% of the subjects reaching the pre-specified eliciting dose, and that there was a significant reduction and difference between the intervention group and the placebo group, which met the pre-specified criteria. In addition, they found that 64% of children were able to reach an eliciting dose of 1,000 milligrams or more of peanut protein. So this came out with the New England Journal of Medicine trial, phase 3 trial of epicutaneous immunotherapy in toddlers with peanut allergy, with a nice editorial from Dr. Toyas. And then following this, there was an open label follow-on study from Epitope, which was the Apopex study. And these were patients who received the Viaskin peanut during Epitope and then on to Apopex. And there was an up to 24-month follow-up of these participants. And you can see here that the treatment responders increased over a period of time. This was up to 84%. And then those were achieving 1,000 milligrams or more eliciting dose was 81%, and those getting up to the full criteria of the double-blind placebo-controlled trial were 56%. So it's reassuring to see that these results improve over time with the duration of the patch application. And similarly, you can find the same thing for oral immunotherapy, that the amount of desensitization improves over time of doing the treatment. So there's some very nice new data now that was published by Edwin Kim and the team on sublingual peanut immunotherapy, which I'm going to present today as a potential alternative. So this was a study that was done and published in 2023, where the children that were included were aged 1 to 11 years of age with a convincing history of peanut allergy that had peanut-specific IgE of over 0.35 kilounits per litre, and they also had a positive double-blind placebo-controlled food challenge to 1,000 milligrams of peanut protein. The exclusion criteria were severe anaphylaxis after peanut exposure, severe asthma, previous peanut interventional study, or previous eosinophilic gastrointestinal disease. And you can see here that they did the double-blind placebo-controlled food challenge at baseline, and then there was a 48-month open-label peanut slit trial, which went up to a 4 milligram maintenance dose. They then had a challenge to look for desensitization status after the 48 months to 5,000 milligrams of peanut protein. And then after that, they were randomly assigned to assess sustained unresponsiveness. And this was an adaptive trial design where they would randomly implement either 1 or 17 weeks of avoidance. And then the individuals would have a repeated double-blind placebo-controlled food challenge of 5,000 milligrams. This is the dosing schedule. So just you can see that some of these were done at home and some of these were done in clinic. And this is some of the novelty of this design, in that a lot of this can be done at home rather than having to come in for every single visit to the clinic. But then as the dilutions increased, they were observed in clinic to make sure that they were doing this correctly. And these are the results, which showed that in the per protocol group, 48-month double-blind placebo-controlled food challenge, there were 36% that could complete 5,000 milligrams without symptoms. There were 70% that completed 800 milligrams or more without symptoms. And this was an increase from 48 milligrams up to 2,723 milligrams at 48 months, which is a substantial increase. Of note, this was not a controlled study, but I think is very interesting in terms of its findings. And then what they found with regards to sustained unresponsiveness was that there was a median time to loss of peanut protein desensitization of 22 weeks for 800 milligrams of peanut protein, but there was no participant that reacted below 300 milligrams of peanut protein. So if we summarize the results from the studies that I have just presented, we have the oral immunotherapy trials, which are Palisade and Poseidon. We have the epicutaneous immunotherapy trials, which are PEPIT and Epitope. And then we have the SLIT trials, which, as mentioned before, is not controlled. And what you can see here is that for the Palisade study versus Poseidon, that the efficacy was better for the Poseidon study, which was in younger children. Similarly, for the peanut EPIT study, the efficacy was better in the younger children, the Epitope study, and it's harder to compare the SLIT trial, but that was a 70% in the per protocol arm. So in summary, with regards to the safety aspects, we know that oral immunotherapy certainly has more concerns with regards to safety in terms of anaphylaxis, but there is better safety in preschool children, and I showed earlier the results of 14.2% versus 2% treatment-related systemic allergic reactions. Then with peanut EPIT, there are fewer safety concerns, although there have been described episodes of anaphylaxis. And for peanut SLIT, there was no anaphylactic reaction, but local reactions only. This is a summary of food allergen immunotherapy, which was published now in 2022. And they've got a big tick for oral immunotherapy, a tick for epicutaneous immunotherapy, but of course this needs to still go through the regulatory processes. And then the oral immunotherapy had a number needed to treat of 2, which is really quite incredible, to increase the tolerance to a single dose of 300 milligrams or 1,000 milligrams of peanut protein. Sublingual immunotherapy, there were still some question marks around that, and I think that it's an exciting area, but does require further study. And then subcutaneous immunotherapy, I've not touched on today, but also is showing some interesting results. What about practical considerations? Now I'm going to show you a video of one of the patient's parents that I treated in clinic who has consented to be part of this presentation. What's been the most challenging thing about doing the oral immunotherapy process?
I think, you know what, it's a bit of a learning curve at the start, because, you know, figuring out the recipe and how to make things and worrying if you're getting things right. And so I find it quite daunting initially, but then, you know, Karen, the nutritionist, was helping us and showing us videos, and it just kind of got a lot easier. And I think by maybe the second month, it was just kind of our routine. So yeah, we initially found it a steep learning curve, I would say.
Mm-hmm. And what were your main concerns at the beginning before starting the oral immunotherapy process?
I think the biggest one was just his safety. And I was, you know, worried, would he have a serious reaction during immunotherapy? And was that something that we were willing to take that risk? And was that something, yeah, that was my biggest worry for sure.
Sure, absolutely. And has your son had any side effects from the oral immunotherapy treatment?
He has had a couple of occasions when we were doing the up dose or increasing his dose where he maybe got one hive, or maybe a little bit of redness around his mouth. So far they've been his worst reactions. Sometimes maybe he has a little bit of tummy ache, but then it's really hard to know, is that linked to the immunotherapy or does he just have a bit of tummy ache or he needs to go to the toilet? But, you know, as you know, we can contact you and send an email of the picture of his hive, and you're always so good at getting back to us and letting us know what the next steps are and, you know, what we need to do to manage those reactions.
Thank you for that. And what would you say the impact of oral immunotherapy has been on your family life?
I would say pros wise, it's you know, given us a lot of power almost. We don't feel so powerless. We don't feel so hopeless to the allergies. And that's a huge thing for us. And we have a lot of less anxiety about cross-contamination. Like if someone's eating a baked milk biscuit around him, we're not as panicked and we're not kind of wiping seats. And I know, he still has lots of other allergies, but we just have a little bit more comfort. And then I guess, the downsides kind of to family life would just be, we have to plan things a little bit better, and kind of factor in what time of day he's dosing and kind of work around that.
Yes, absolutely. And taking it all into consideration, would you recommend this to other families who have children with food allergies?
Yes, and I do all the time because I'm kind of on the allergy groups on Facebook or Instagram, and I think the vast majority of people just want the information to know that it's there, and I'm always happy to kind of share our experience. And yeah, I think just feeling like you're doing something proactive has been for us really important. Yeah.
Yeah. And having been through this process, what are your top tips for other families thinking about oral immunotherapy?
Oh, that's a good one. I think that initial anxiety got a lot better much quicker than I thought it would. So initially, I remember giving his very first dose, my hand was shaking. And by maybe a week later, it just felt like it was kind of normal and I felt really comfortable doing it. And I think another top tip is probably just follow the golden rules, which is something I guess you'll be talking to the families about if they do go through with it. But just, I like, for example, one day we forgot to put on his barrier cream and then he got a hive that day. And I was just like, why did I not just follow the golden rules? So we kind of always try to keep those in mind.
So I think that that interview just shows some of the real life experience of a parent undergoing multiple food immunotherapy. And I think that some of the things that she was mentioning with regards to following the golden rules, that is probably one of the main things that are negative for people undergoing oral immunotherapy. And of course, we have to do this for safety reasons, but I think it's really important that for future, we need to look at ways to be able to better predict when we can start to relax some of the aspects with regards to oral immunotherapy so that we can improve their quality of life and we can get to some of the expectations that I mentioned at the beginning of the presentation with regard to, for example, free eating. So in terms of research needs, I think peanut oral immunotherapy leads the way. More studies are needed in other foods. There is some fantastic work that's being done in Israel on tree nut immunotherapy and all around the world as well, which I haven't had time to present today. I also think that we need to have more long-term data on remission in preschool children so that we know exactly what these people are going into when they're having perhaps reduced frequency of dosing. And I know there's some great work ongoing in Australia with regards to this and in other centres. We need to have an optimal timing of OIT versus natural resolution, particularly for the preschool children. I think it's even harder to think about whether a child should undergo milk or egg immunotherapy if they're between the ages of 1 and 3. But also 20% of children outgrow their peanut allergy. So it would be really good to know. We do have, typical IgE results or previous history of severe reactions, but a better biomarker would be good. And then I have a lot of patients who have come to the end of their 1 year of maintenance dosing, and they are very keen to now, relax the golden rules or reduce down to 3 times a week or reduce the dose, or they want to take another step forward. They certainly don't want to stop doing the treatment because they don't want to lose the benefits they've achieved. And it would be wonderful to have a biomarker at that point that we could do some kind of blood test to say, well, your child looks like they're likely to be one of the ones that would have had sustained unresponsiveness, or even have this right at the beginning of the study or of the process. And yes, a biomarker or some kind of understanding as to when children who are on oral immunotherapy can stop having to not do sport for 2 hours or stop the process when they're unwell. And all of this is still, very much an area that needs to be explored. So with that, I'd like to just make a plug for the BSACI meeting, which is between the 2nd and 5th of October, which will be in Harrogate, which will be a very exciting conference. And I'd like to thank all of the team that I'm working with. Particular thanks to Karen Wright at Eat, Thrive, Flourish for her help with obtaining this video.